The scenario this morning is we've been called to a 72-year-old gentleman that has a cardiac history, and he experienced an onset of central chest pain when he awoke this morning. He's taken his own GTN and the symptoms have now resolved. He called the ambulance prior to taking his GTN. So the first thing we're doing is we approach the situation is making sure that the scene is safe. We have our gloves on and we introduce ourselves to our patient. Good morning, sir. My name is Bruce. Can you tell me your name, please?
Fred.
Morning, Fred. I believe this morning you've had an onset of central chest pain. Do you have pain at the moment?
No.
Okay, that's great. Thank you very much. Fred, I just need to try and ascertain what's going on. We need to have a bit of a look at your chest, have a bit of a look at your heart, and see if we can find out what's going on today, and just look and see if there's anything else that could be causing this issue that you've had this morning, other than just your normal angina. Is that okay?
Yeah.
Great, thanks. First, I'm just going to have a look at expose your chest so that we can see more easily what's actually happening. So primarily, as we walk in, we're looking at our patient. We're deciding, are they sick or are they not sick? Part of that criteria is looking at their colour. So are they grey, are they pale, are they diaphoretic, are they sitting there clutching their chest, and just looking at their seating position. As part of our as we arrive, we're looking at an overview of the whole scene. So looking around the patient themselves, looking at their whole demeanour. Is there any equipment around them, like a CPAP machine or oxygen? Are they clean? Do they appear like they're managing to look after themselves pretty well? As we expose the chest, we're looking for scars. We're looking at the colour of the chest. At this point, we would engage with the patient, looking to obtain a radial pulse. This tells us of the mechanics of the heart, so whether they are tachycardic, bradycardic, whether their rate or their heart rate is regular, whether it's bounding, which could indicate a high blood pressure, or whether it's thready, which could indicate a struggling heart. At this point, we would also look at ascertaining a blood pressure. This is telling us how hard the heart is working, whether the patient is suffering from any arteriosclerosis if they have high blood pressure, or if there's something else mechanically that's not quite right. As we're touching the patient at this point and taking their radial pulse, we can also ascertain their skin temperature, whether they feel clammy, and looking at their peripheral perfusion as well, so the colour of the hands, how quick their cap refill is. Asking the patient whether they are short of breath, either on exertion or just lying still. We would also continue our baselines by gaining a rest rate, looking at their work of breathing, so are they struggling for breath, is there any indrawing around the neck, those sorts of issues. At this point, we would also attach a 3-lead ECG. This would give us an indication of the mechanics of the electrical output or the electrical works of their heart, and if there's anything there that we need to be concerned about immediately. We start the actual physical hands-on inspection, looking at the neck, looking for jugular vein distension. This could indicate an increase in interthoracic pressure. It could also indicate potentially heart failure as well, so the blood's backing up to the heart as the cardiac output is insufficient. Looking at the chest, we're looking for indications of trauma, indications of deformity. We're looking at the colour, so for central cyanosis, which could indicate a more acute cardiac issue. We're looking to see if there's any indrawing. If they indicate pain in a specific area, we would also feel in that area to make sure or to see if there is any increase in pain on palpation. We would take the temperature, trying to discount any potential infection, and starting the differential diagnosis process, trying to rule out what else could be going on. As part of that process, we use a mnemonic OPQRST. The O is for onset, when this started. The P is for what provoked the pain. So were they at rest? Were they walking? Were they running? Walking upstairs? What region the pain is in. So if it is essential chest pain, if it is radiating anywhere else, up into the neck, down the left arm, can also radiate down the right arm, radiating through to the back. Severity, we ask the patient to score their pain from 0 to 10. 0 is no pain at all, 10 is severe, horrendous pain. We ask for the time, how long that pain has been there. Is it still there? Does it come and go? The second part of our mnemonic, we use the word sample. This is asking signs and symptoms. It's asking if the patient has any allergies, what medications they are on, if they've had any medication change recently. We also ask about their past medical history. Do they have a history of heart disease? Have they ever had any heart attacks, any strokes? Do they have diabetes? We ask them about their last oral intake. So have they taken their medications? Have they eaten this morning? And we ask them what events or what happened prior to this pain starting. As part of this process, we're trying to ascertain whether we are dealing with a cardiac issue or we are dealing with another form of chest pain. Non-cardiac chest pains, we're trying to rule out pneumonia, pulmonary embolism, pericarditis, pleuritic chest pain, pneumothorax, a musculoskeletal issue, so if they've had any trauma, or if they've had a fall. If they have a AAA, which could create referred pain through the chest and through to the back, gastric issue, gastric reflux, and we've already spoken about trauma or falls, whether they've had a cough or cold recently. We'd also ask the family if this is a normal presentation for the patient. We'd ask the patient whether they have been well recently, how their oral intake is, are they eating and drinking normally, and whether they're toileting normally. While we're asking these questions, we generally continue our assessment, so we have our hands-on assessment at the same time, and at that time we would be looking at palpating the abdomen, checking to see if there's any referred pain, and palpating the 4 quadrants of the abdomen. We would look at the legs, looking for pedal edema, which would indicate congestive heart failure. We're looking at that pedal edema as pitting, so as we press our freeman, how long it takes for that edema to disappear, or for the pitting to disappear. We're also looking at we've looked at hands colour. We would also look at the patient's back to ascertain if there's any trauma on their back, and to look at the mechanics of breathing again, as far as looking at the back. At this point we would look at auscultating the heart valves, looking right of medial for the aortic valve, left of medial for the pulmonary valve, left of medial just above the nipple line for the tricuspid valve, and just below the nipple line for the mitral valve. At this point we would also try and auscultate the lower lungs from side to side, listening for any abnormal lung sounds which could indicate fluid, cardiogenic pulmonary edema or congestive heart failure. So from here we can say that our patient is pain-free. Our theory could be that this patient has had some angina this morning that has been resolved by taking their own GTN spray. We would still advise this patient to be seen in hospital and transport them as a status 3 patient. Status 3 indicating that they're medium acuity. We would look at treating them with some aspirin, antiplatelet aspirin, and acquiring a 12-lead ECG, looking for any abnormal heart rhythms.